Okay, so the pharmacokinetics of the IV anesthetics. I'm going to separate this topic into two videos. The first one is going to discuss the constant argument between the surgeon and the anesthetist. Why did the patient awake during the procedure? I will try to answer this question by telling you a short story about a cool anesthetist. This is the anesthetist and this is my patient, a 24-year-old male who's undergoing laparoscopic cholecystectomy. Okay, so this is my syringe which I'm going to give the IV drug, propofol, etomidate, ketamine, midazolam, whatever drug you want, throw it. Okay, and this is the IV giving set, the ringer lactate, the maintenance fluid, and this is the cannula of my patient. Okay, this is the surgery team, angry, rushing me to anesthetize the patient as soon as possible. Okay, so patient is well pre-oxygenated, he is on monitor, everything is good, I'm ready to go. I'll give my patient the drug through this syringe. Okay, what actually happens, the journey of the IV anesthetic starts from this syringe into the IV giving set and in the veins of the patient arm, and from the veins of the patient arm to his heart through the circulation to the right atrium, right ventricle, pulmonary circulation, and eventually left ventricle, and from the left ventricle into the aortic arch. This is the aortic arch. Okay, and from the aorta to the brachiocephalic artery and to the internal external carotid, and from the internal carotid arteries into the brain. Okay, now we are in the brain. In the brain, the drug will pass from what the so-called the blood-brain barrier into the receptors, the GABA and the NAMDA, whatever receptors, the receptors I talked about in previous videos. Okay, and depending on the percentage of the drug that occupy the receptors, or the percentage of the receptors occupied by the drug action will happen. Okay, maybe an exeresis of as small as 20% of the drug occupying the receptors, or hypnosis if 60%, for example, of the drug occupies the receptors. Okay, so the period between giving the drug into the patient arm and the action of the drug into in the central nervous system is called the brain arm circulation. The brain arm circulation, it is the time required for the drug to apply its action, okay, after giving it, or it is the same concept as the distribution time, of the drug. So when we give the drug, it takes time to act. Okay, and this time is the time for distribution of the drug between the blood and the central nervous system. And actually this time depends on many factors. The first of them is the lipid solubility. You know, this is, for example, a lipid bilayer. Okay, this is the lipid bilayer, and this is our drug. Actually, most of the membranes of the body depends on the lipid solubility to pass the molecules through it. Okay, so the more the lipid soluble the thing or the molecule, the more the accessible it is through this membrane. Okay, so the more the lipid soluble, the faster the action of the drug. This is the first thing. The second thing is the ionization of the drug. Actually, most of the membranes are ionized, and it does not like the ionized molecule to pass it through it. So the less the ionized the drug, the faster the action of it. Okay, so the lipid solubility, the ionization, the more the non-ionized, the faster the action of it. The third thing is the protein binding of the drug. So when I give this drug into the blood, most of the drug molecules will bind to certain proteins in the blood. For example, albumin or glycoprotein, whatever. Okay, the protein binds. A small fraction of the drug will left unbinded. This small fraction of the drug is the fraction that act on the receptors. Okay, so the more the protein binding the drug is, the less the action of it in the same period of time. So drugs that has a lot of protein binding or a high percentage of protein binding, like propofol, for example, 98% diazepam 98%, lorazepam 98%, midazolam 94%, thiopental 85%, etomidate 75%. Most of the IV anesthetics has a high percentage of protein binding. Ketamine is the least to bind with proteins, with a 12% only. So from this point of view, from the protein binding point of view, ketamine should act faster than propofol and etomidate and lorazepam and diazepam and etc. Okay, but actually this is not the only factor that determine the rapidity of action of the drug, or the distribution of time of the drug, or the arm-brain circulation of the drug. So ketamine actually takes about 11 to 16 minutes to act, whereas propofol takes about only 2 to 4 minutes. Okay, 2 to 4 minutes, and etomidate 2 to 4 minutes, and thiopental 2 to 4 minutes. Although these drugs has more protein binding than ketamine. Okay, but the other factors, the lipid solubility, the ionized fraction of the drug, and all these factors also determine the brain arm circulation. Okay, so these are the three factors: the solubility, the ionization, and protein binding. The fourth factor is the perfusion of the brain. The perfusion of the brain. Actually, we divide the tissues of the body into four main categories. The first one is the vessel-rich organs like brain, the heart, the kidneys, the endocrine glands, and so on. Okay, these vessel-rich organs constitute about 10% of the body weight. Okay, but although they have a very small percentage of body weight, okay, the blood supply to these organs is the most. Okay, they have about 75% of the blood supply to the body. Okay, the muscle, which is the second compartment, let's say, or the second group of this classification, constitutes about 50% of the body weight. Okay, but they have only about 20% of the blood supply. The fat, 20% of the body weight, and 6% of the cardiac output. Okay, the vessel poor organs like cartilages constitute about 20%, just like fat, and have zero blood supply, almost zero. Okay, so the blood supply to the organ, the perfusion to the organ, determines the rapidity of the action. The faster the cardiac output, the faster the heart rate, the more the stroke volume is, the faster the drug will go from the heart to the central nervous system, and the faster the action of the drug. Okay, so fortunately the brain has about 20% of the cardiac output, which is a high percentage, and this is why the drugs act on the central nervous system act fastly. Okay, act fastly, because most of the drugs are very lipid soluble. Most of them has no the non-ionized fraction is a big one. Okay, and because of the perfusion to the central nervous system, brain is very good. Okay, so this is, let's get back to our story. I gave the patient the drug, and the drug went to his vein and to the central nervous system eventually. And the patient now is anesthetized. The patient is hypnotized. Here I'm happy, and I'm not giving the patient the IV drug anymore. The patient is asleep, as you can see here. Okay, minutes later I heard a screaming sound. I looked at the surgeon. He was freaking out, shouting why the patient is awake, and I looked to the patient. He's also freaking out because he's awake. Now the question: why did the patient awake after the first dose of my IV drug? Why? The answer is, when you give the patient the IV anesthetics, as I told you, it will go first to the brain in a fast manner, because the brain has the 20% of the cardiac output. Okay, so the drug will go to the brain and apply its action. But still, you have to remember there are other tissues. It's right that the drug went to the blood, and from blood to the heart, and first to the brain. But still there is a circulation, and the circulation will not go just to the brain. Okay, it will go to the muscles, it will go to the skin, it will go to the fat, and so on. Okay, so depending on the lipid solubility of these tissues, the drug will go. Depending on the perfusion of these tissues, the drug will go. Okay, so the perfusion is most to the brain. Okay, but still the muscles have 20% of the cardiac output, so the drug will go to the muscles. The drug will go to the muscles. So you have the constant amount of the drug in the patient blood. Okay, and you're not giving your IV anesthetic anymore. This constant amount went to the brain first, but after which the drug will move from the brain to the circulation, and the question is why. The answer is that when you give your IV anesthetic, it will go to the brain first, and after a few minutes it will go to the muscles. It will go to the muscles, and when it goes to the muscle, the concentration of the drug in the blood will decrease, and the difference between the drug concentration in the brain and in the blood will be set. Okay, so the drug will move back from the central nervous system into the blood. Okay, so the scientists call this phenomena the compartment model, or the multi-compartment model, that when you give your drug, it will go to the blood and then to the brain, okay, and after which to the muscles. When it goes to the brain, the action of the drug will start and the patient will be hypnotized. After a few minutes, the muscle will start to be perfused, and the concentration of drug in the blood will decrease, and the gradient between the brain and the blood will be set, and the drug will move from the brain into the blood, and the concentration of the drug in the receptors of the brain will decrease, and this will at certain points awake the patient, and the patient will be awake, the surgeon will be freaking out, everything will be bad, and you will be just la la to the surgeon. Okay, so after this, the drug will not just go to the muscles of the body, it will also go to the other tissues, the fat tissues, for example. But to be precise, the fraction of the drug that goes to the fat tissues is not that much, especially in short procedures. If we have a long procedures that last more than 4 hours, for example, okay, then you will take the fat absorption of the drug into account. But the short procedures, which is half an hour or an hour, the fat absorption of drug will not be that much. Okay, so we concern about the brain concentration and the muscles concentration of the drug. So the first compartment is the vessel-rich organs, the second compartment is the muscles, the third compartment is the fat, and the fourth compartment is skin and the other tissues. Okay, so this is the multi-compartment explanation for this phenomena. So when you give the blood, it is the distribution of the drug that determines the action of the drug, and the first awakening of the patient after the first dose of the drug, okay, is it due to the redistribution. Redistribution is the backflow of the drug from the central nervous system into the peripheral compartments like the muscles and the fat. Okay, it is responsible for the first awakening of the patient after the first dose of your drug. So this is the first part of my story. The second part of my story is the distribution of the drug to the brain. The patient is asleep. The third part of it is the redistribution from the brain into the muscles and the fat tissue. And the fourth part of the story, okay, the patient is awake in the third part. And so what I'm going to do is I'm going to give the patient furthermore doses of the drug, and he will get back to sleep. And after multiple doses of your drug, of your IV anesthetic or an infusion manner of giving the drug, okay, the main factor that is responsible for the cutting the action of the drug is the elimination of the drug, not the redistribution. Redistribution is the main factor to determine this just in the cases of one dose drug giving or in very short procedures. But if you have longer procedures, multiple doses of your drug or continuous infusion of your drug, now the elimination of the drug through the liver and the kidney is the main thing to determine the action of your drug, okay? So elimination of the drug means the metabolism of the drug in the liver, okay, to water soluble molecules, and these water soluble molecules will go then to the kidney, okay, and in the kidneys it will be excreted. Actually, in the liver, some of the drugs will be metabolized into active metabolites, like norketamine, for example, a famous active metabolite of the ketamine, or the alpha hydroxymidazolam, okay, the active metabolite of the midazolam, or the oxazepam. Many active metabolites. Most of the metabolites are inactive, but some of them, like norketamine, oxazepam, and hydroxymidazolam, are active metabolites that may prolong the action of the drug, okay? Now there is a question: what if the liver is cirrhotic, or the patient is having liver cirrhosis, deranged liver function, or so on? What will happen to the action of the drug? Actually, it's a little bit more complicated than it appears, but to talk about this in a simple way, I'm just going to put you into two pictures. The first one is the protein binding of the drug. If we have malnutrition or derangement of the liver function, the liver will make less proteins, okay? Less proteins means more free fraction of the drug, so the drug will act in a faster manner, okay, and it will take more time to be metabolized by the liver, okay, because there will be a more free fraction of the drug, okay? So mainly when we talk about liver failure, we need a high percentage of liver derangement to have a problem when giving drugs such as propofol, for example, is the most because okay, so I'm going to talk about this in details in the next video, inshallah. Okay, so I talked about the arm-brain circulation, the route of administration. We are talking about IV anesthetics. In other videos we will talk about inhalation agents and oral drugs and rectal drugs and intramuscular drugs and so on. I talked about the distribution, because the bioavailability of the drug when you give it in the IV is 100%, there is no absorption, and redistribution, the main responsible for the first awakening after the first dose of the drug, the protein binding of the drug, the metabolism and excretion of the drug will be the main thing that we'll talk in the next video. Okay, so this is our little story. Thank you very much. See you in the next video.